This morning's lecture again is going to be looking at right heart cath from the perspective of left to right shunt, and we're gonna see how you can use a right heart cath, or you can do right heart cath to evaluate a left to right shunt. And when we talk about a left to right shunt, we're talking about any communication between the left heart and the right heart, which gives rise to a mixture of the oxygenated blood with the deoxygenated blood. So one of the most common left to right shunt is atrial septal defect. And again, remember that the atrial septal defect can be multiple locations. You can have the sinus venosus type of defect with the defect being high in the atrial septum. You can have it in the secundum, in the mid portion of the atrial septum, or the lower portion of the atrial septum, the primum. Those are atrial septal defect, and they're probably the most common cause of left to right shunt. So you have the mixture of blood of the oxygenated blood with the deoxygenated blood. So immediately you can see that the oxygen saturation if we're talking about the atrial septal defect, then the oxygen saturation in the right atrium is going to be increased, also in the right ventricle and the pulmonary circuit. So when you have a left to right shunt, you are mixing of the blood from the left side of the heart with the right side of the heart. So one of the things, increasing oxygen saturation or content. All right, so there are other shunts, a ventricular septal defect, the same thing. You have mixture of blood, the left side of the heart, the right side of the heart. So the oxygen step up, increase in the oxygen saturation is not going to be at the atrial level. It's going to be at the ventricular level now. And also when you look at the pulmonary trunk and the pulmonary artery, the oxygen saturation is also going to be increased. Okay? As opposed to an ASD, atrial septal defect, where the oxygen saturation increases from the atrium. So you can also have what we call a PDA, a patent ductus arteriosus, where you have a communication between your aorta and the pulmonary trunk. So you're going to have mixture of your oxygenated blood from the aorta into the pulmonary trunk. So the oxygen step up is not going to be at the atrial level. It's not going to be at the ventricular level. It's going to be at the pulmonary artery level. That's where you're going to get your oxygen step up. We also have anomalous pulmonary venous return. It can be a partial or it can be a complete anomalous pulmonary venous return. So, the normal, so you have to know the normal anatomy and the normal physiology. We know that the oxygenated blood from the lungs goes to the left atrium via the pulmonary veins, and there are 4 pulmonary veins. But sometimes you can have these pulmonary veins draining into the right atrium, the superior vena cava, or the inferior vena cava. You can have a partial or a complete. So, this is a complete where the pulmonary vein join up to drain into the superior vena cava. Now, for this fetus or for this fetus to survive, you need some communication. So you commonly will have like a ASD, atrial septal defect, so that at least they can get some oxygenated blood on the left side. But you can have partial anomalous pulmonary venous return, where just probably 1 or 2 of the pulmonary veins drain into the right atrium. You can again, You can have the pulmonary veins coalesce and then drain into the inferior vena cava. Okay, so this would be like an infracardiac shunt. So you can see that the pulmonary veins, they drain into the inferior vena cava. Similarly, they can drain into the superior vena cava. Um, Again, you can have partial or complete. Complete, you need some type of shunt between the right side and the left side for the infant or the fetus to survive. So remember that. So when we do a right heart cath to evaluate a left to right shunt, um, there are certain things that you need to do. We talk about the oxygen run, and we'll explain what an oxygen run is. So you're going to do your oxygen run. You're going to do your flow ratio, which is your pulmonary flow to your systemic flow. You're going to do your indicator dye dilution technique, and you want to do angiography to see what's going on, and you do your pressure measurements. So these are the different things you will do in your catheterization for someone who has a left to right shunt. Your oximetry, you want to see if there's any oxygen step up, as we explained. Flow ratio, because if you have a left to right shunt, the magnitude of the shunt is going to affect your pulmonary flow. And if the pulmonary flow increases and sustain increase, you'll get pulmonary hypertension, and that's going to affect the disease process. It's going to make the disease worse. So you need to do your flow ratios. That also helps us to determine when surgery is necessary. Um, uh, the indicator dye dilution, we when we're doing flow, we usually use the thermodilution method. And then angiography, if you want to actually see the defect. Say the patient has a ventricular septal defect. You can do angiogram to show that the patient has a ventricular septal defect. And then your pressure measurements, which is very crucial. So when we do a oxygen run, basically we're just going to take blood samples and evaluate those blood samples. We're going to do saturation levels. So we'll do multiple blood samples and send it to the lab, and they'll give us a saturation. Okay. All right. So remember, when you do your right heart cath, your access could be from the upper limb or the lower limb, but you're gonna enter the right heart. Uh, we're gonna do oximetry or oxygen content, and we measure that in the right atrium. So we usually talk about, we can do it in the high right atrium. That is just where the superior vena cava enters the right atrium, because, say you might have an atrial septal defect, the ostium venosum defect, which is high up, or you might have an anomalous pulmonary venous return. So you want to do an eye right atrium. You take a sample. So with your catheter in the atrium, you're gonna make your catheter lie in the atrium, and you're going to get a sample. So you take a blood sample and you send it to the lab, and they'll give you oxygen saturation. Then you also do the mid-right atrium. You insert the catheter a little bit lower, and you take blood samples, send it to the lab. And then low right atrium, you insert the catheter even lower, and you take blood samples. You can also take blood samples or you should take blood samples also from the superior vena cava and the inferior vena cava. And then when you enter the pulmonary trunk, you're going to take blood samples at different levels in the pulmonary trunk. Because remember, you can get a PDA. With a PDA, patent ductus arteriosus, the defect is between the aorta and the pulmonary trunk, and you have to get inside the pulmonary trunk, and you have to analyze the length of the pulmonary trunk to see if there's an oxygen step up. Okay, so those are the different areas you're going to take your blood samples. So it's multiple blood samples, and you have to label them. You have to label them. So a left to right shunt may be detected and localized if you get a significant step up in blood oxygen saturation or content if found at one of the right heart chambers. So essentially, if you have a communication between the left side and the right side, and you have mixture of blood from the left side with the right side, the oxygen saturation in the right side is going to be increased. And that's basically all we're checking for. A significant step up, however, is defined as an increase in the blood oxygen content or saturation that exceeds the normal variability that might be observed if multiple samples were drawn from the cardiac chamber. So you have to know the range, okay? And appreciate that there's a range in the normal saturation at different levels. And what you want, you're looking for something that exceeds it. So you have to have an idea of what normal saturation, normal pressures are. So again, this is your superior vena cava drains into the right atrium, inferior vena cava drains into the right atrium, and the average saturation of blood in the right atrium is about 75%. The average saturation of blood in the right atrium is about 75%, and in the right ventricle is approximately the same 75%. In the pulmonary trunk is about 75%. Then you have your left and your right pulmonary artery, which goes to the lungs. The blood becomes oxygenated and it comes to the left side of the heart via the pulmonary veins. And the saturation is about 95% in the left atrium, about 95% in the left ventricle. And then in your aorta, it's about the same 95%. So in the aorta, it's about 95%. So this is your normal scenario. So you have an idea of your normal scenario. But however, if you have a communication between the left heart and the right heart, you're going to have an oxygen step up in the oxygen saturation on the right side. So this is how we do the oxygen run. So again, in the right atrium, we talk about the high right atrium. So when we talk about high right atrium, we do the sample right up there. Okay, let's highlight this a little bit better. So your high right atrium, so you take a sample from right up here. Mid right atrium, you take a sample right there, and then your low right atrium, you take a sample way down here, because you can have communications between the left and the right heart at different levels. You also want to get a sample from your superior vena cava, and you want to get a sample from your inferior vena cava as well. And then, after the atrium, you move to get a sample from the right ventricle. You get a sample from your pulmonary trunk, but you want to get it, you want to get it the full length of your pulmonary trunk. All right, so this is how you do your samples. All right, so this basically, and you want to get a sample also from your left ventricle and your aorta as well. Okay. When you have an atrial septal defect, again, you have a communication between the left atrium and the right atrium. And if your step up is more than 7%, you have to think that there is some communication between the left atrium and the right atrium. Usually it's probably ASD, but remember, you can have anomalous pulmonary venous return as well. So we talk about a step up of 7% or more. Okay. At the ventricular level, so you're taking your samples from the right ventricle. If the step up is more than 5%, then you think in terms of a VSD. And then in your pulmonary trunk, if it's 5% or more, then you think in terms of a PDA. So you're just taking blood at different levels to see where you get your increase in oxygen content, which suggests that there's a mixture of the blood from the left side with the right side. And then these are just some the normal values that we went over, but the range. So it's not going to be a fixed value in everybody. It's a range. So your superior vena cava going to range from 67 to 83%. This is saturation. Inferior vena cava 65 to 87% with an average of 78. Your right atrium average 75, and then the range is from about 65 to 87%. So remember, when the lungs oxygenate the blood and the blood goes to the left side of the heart, it's pumped out of the left heart via through your aorta, and then all the organs and tissue are going to get rich oxygenated blood, and then they're going to use the oxygen out of the blood. They're going to use the oxygen in the blood to produce energy. The reason why we need oxygen is, oxygen is necessary for the production of energy. Okay, so that for you to do stuff. So when the oxygen is removed from the blood, then it goes into the venous system. So the blood goes into the venous system devoid of oxygen or depleted of oxygen. So that is why the oxygen in the right side of the heart, where all the veins drain their blood, is going to be much lower than the arterial side. All right. So that is the oxygen step up. So you're just looking for an increase in the oxygen level, and that will tell you or indicate that there's a communication between the chambers. We can also do angiogram. That is, we inject contrast material into the heart, and we can see some of these defects. So with an atrial septal defect, if we inject contrast material into the PA, we can see, and we do what we call a steep LAO view. We can see the atrial septal defects. So we'll demonstrate this in the cath lab. How it's done. Okay, you just have to take care in doing these things. So for a ventricular septal defect, your catheter is going to be in the left ventricle. Okay, and you're going to inject your dye. So for you to get your catheter, we usually use a pigtail catheter. So this is a left heart catheter. This is left heart catheterization. So your catheter enters the left ventricle. We usually use a pigtail catheter, gets into the left ventricle, and we can use our LAO view or RAO. Okay, right anterior oblique view, or we can use your left anterior oblique 40 degrees, and we'll demonstrate these views because it might not mean anything to you right now, but it's how you handle the camera over the patient. It can be on the left side or the right side, and it can be 30 degrees. You can have a direct right atrial view, or you can have your right atrial, your right anterior cranial, right anterior caudal, or right anterior oblique. So these are different views. But to look for VSD catheter in the left ventricle, and we inject dye, you can do your right anterior oblique view 30 degrees, or you can do your left anterior oblique 40 degrees. For a PDA now, that is your communication between your aorta and your pulmonary trunk. The catheter is gonna be in your pulmonary artery or the aorta, okay? Because you have a communication between these two vessels. So the catheter is in the pulmonary trunk. You inject your dye, and your camera is going to left anterior oblique 60 degrees, or your right anterior oblique caudal. Okay, so these are just the position of the camera over the patient, so you can get a very good view, or you can do a, a left lateral. So the catheter is in the PA, pulmonary artery, or the aorta. For your atrioventricular septal defects, your catheter in the left ventricle, and you're going to inject dye, okay? LAO view. So you can do angiogram. We do not do a lot of angiograms to evaluate these shunts or these defects, because echocardiogram is a very good technique to analyze some of these shunts, and we can also use CT scan or MRA to look at these shunts. So we don't do a lot of catheterization to angiogram to look at these shunts. All right, but what we do, we use our right heart cath to evaluate the shunts, and we use it to calculate cardiac output. And this is important because say you have a atrial septal defect or a ventricular septal defect. Over time, if it's a significant shunt, you're going to get increased pulmonary blood flow, and that pulmonary blood flow is going to increase the pulmonary vascular resistance, and it's going to make these patients very sick. So we use the pulmonary blood flow over the systemic flow to tell us, to give us an indication when the patient start to deteriorate, and we use it to help us to plan surgery, or if your what we call a QP/QS ratio is more than 1.5, it suggests that the patient now is probably in need of surgery. And definitely if it's approaching 2 or greater than 2, that is your QP/QS, then these patients should go on to surgery. So again, your QP mean pulmonary blood flow, and your QS is your systemic blood flow. It's basically the cardiac output. And when we do our catheterization, cardiac output is equal to what we call oxygen consumption divided by the arteriovenous oxygen difference. So this is a formula that you need to be familiar with. So your cardiac output is equal to your oxygen consumption divided by your arteriovenous oxygen difference. And for your pulmonary blood flow, or your output looking through the pulmonary circuit, is equal to the oxygen consumption, which is in mLs per minute, over your pulmonary venous oxygen content minus your pulmonary artery oxygen content. So this is the formula for your pulmonary blood flow. For your systemic blood flow, it is oxygen consumption divided by the arterial oxygen content minus your mixed venous oxygen content. And your mixed venous oxygen content is the oxygen content in the pulmonary trunk. Okay? And your this is your arterial oxygen content, which is any arterial system you can get this from your aorta. Okay, so that's the formula. So again, your cardiac output is equal to oxygen consumption. Okay, oxygen consumption divided by your arteriovenous oxygen difference, and the oxygen consumption is in mils per ml. And then the arteriovenous oxygen, if you're talking about the pulmonary circuit, then it's the pulmonary venous oxygen content minus your pulmonary arterial oxygen content. And then for the systemic, it is your oxygen consumption again over your arterial, which is we usually use the aorta, minus the mixed venous O2 content, which is the pulmonary artery. Okay. Once you use this a few times, you'll be familiar with it. To look at oxygen consumption, oxygen consumption is the oxygen you inspired minus the oxygen that you expired. Because you inspire the oxygen and it's gonna go into the bloodstream and go to the left side of the heart, and then you're gonna blow out some amount of oxygen. So that's the difference, is the oxygen consumption. And these are some of the methods that we use to measure oxygen consumption. We talk about the Douglas bag or the paramagnetic methods. Methods to all right. So we look at our oxygen step up. Because you have a left to right shunt, the oxygen content on the right side is going to be increased. We look at angiograms, that is injecting the contrast material and look to see the defect. I say we don't do a lot of that because echo is very good and your CT scan and MRI is very good in that respect. And sometimes it's a little dangerous to do an angiogram in someone with a significant shunt. We also look at the blood flow. We can calculate output, cardiac output, using the right heart cath, looking at oxygen consumption and arteriovenous oxygen content. A very important use of the right heart cath is to measure pressures. Because if you have, say for instance, you have a significant left to right shunt, over time you're going to get increased pulmonary blood flow, and that's going to increase not only the pulmonary pressures, but it will increase the pulmonary vascular resistance. Okay? Again, when you put your catheter into the right atrium, you get your right atrial pressures, and we went over that the last time. It's not a one pressure. We talk about the A wave, we talk about the X descent, we talk about the V wave and the Y descent. So those are the different aspects of the right atrial pressures, and you need to go over them, know what each wave and descent means. And then once you move from your right atrium, you crosses the tricuspid valve in the right ventricle. This is what the waveform looks like. So you have to be familiar with the waveforms. You're going to have a systolic and a diastolic wave. Systolic pressure, diastolic pressure. And the systolic pressure is, probably 25 to 30. Diastolic pressure in the right ventricle is very low. And then you move your catheter now and you enter your pulmonary artery. You get your diastolic step up. Your diastolic pressure is now not close to zero, but the diastolic pressure is, probably 8 to 10 millimeters mercury. Systolic pressure is going to be in your pulmonary artery. The systolic pressure is going to be similar to the systolic pressure in the right ventricle. So systolic pressure in the pulmonary artery is going to be similar to the systolic pressure in the right ventricle, unless you have an obstruction right here. If you have an obstruction at the right ventricular flow tract, then the systolic pressures are going to be different. Okay. All right. So this is what your PA pressure looks like. And then when you do your pulmonary capillary wedge pressure, you go all the way out and you go into the capillaries and you stick your catheter there. So this pulmonary capillary wedge pressure is actually a reflection of the left atrial pressure. It is a measure of the left atrial pressure. But you know, we didn't enter the left side. We didn't enter the left side. We use our right heart catheter and we extend it all the way into the capillary system. And these capillaries actually reflecting the pressures in the left atrium. The pressure in your left atrium or your wedge pressure is going to be higher than the right atrial pressure, but you'll have the same waveforms. You're going to have your A wave, you're going to have your X descent, you're going to have your V wave, and your Y descent. Okay, pressure is going to be higher. So you have to know the normal pressures, because again, if the pressures are elevated, you need to know that the pressures are elevated. So the right atrial pressure is usually probably 3 millimeters mercury, range of 1 to 5 millimeters mercury. For your right ventricular peak, the range is about 15 to 30. End diastolic pressure in the right ventricle is usually pretty low. 4, rarely goes up to 12. And your pulmonary capillary wedge pressure ranges from 4 to 12. Your PA pressures, your diastolic, you're going to get your diastolic step up from the right ventricle. So it's important to know the waveforms, because when we're doing right heart cath, by just looking at the waveform, you know where you are, because sometimes it's difficult to just look and see where you are, but the waveforms will definitely tell you where you're located. Vascular resistance is a very important test that we do, and because your vascular resistance will tell you, the resistance or the half the load that each ventricle is looking at. So for the left ventricle, we talk about the systemic vascular resistance. That is the resistance to blood flowing into the aorta from the left side, and then from your right ventricle, the pulmonary vascular resistance is going to tell you the resistance that the right ventricle is going to be faced with when it's pumping. And so one of the things that we do when we do right heart cath is to do pulmonary vascular resistance measurements. We talk about a transpulmonary gradient. So basically, it's a pressure gradient for blood flowing into the pulmonary circuit. So that pressure gradient is the mean PA pressure minus the pulmonary capillary wedge pressure. So remember, our pulmonary capillary wedge pressure is a reflection in the left atrial pressure. Blood flowing from the pulmonary circuit into the left atrium gonna encounter a gradient, and that's what we call the transpulmonary gradient. Okay, and when we talk, the gradient is the pressure difference. So it is the mean PA pressure minus the left atrial pressure, but our pulmonary capillary wedge pressure is a reflection of the left atrial pressure. So this pressure difference is our transpulmonary gradient. And your pulmonary vascular resistance is equal to the transpulmonary gradient divided by the cardiac output, or the output in the pulmonary circuit. Remember, we just went over how you calculate your pulmonary output, or the pulmonary flow. So that's oxygen consumption over your your AV, oxygen content. For the pulmonary artery, it is your pulmonary vein minus the pulmonary artery blood content. So the pulmonary vascular resistance is your transpulmonary gradient divided by the output, cardiac output. And the unit is Wood's unit. Okay? So you have to know the unit. So it's Wood's unit. If you want to get another unit, and so this is the metric system, the Wood's unit. If you want to use the older unit, which is dynes seconds per centimeters to the -5, you have to multiply it by 80. Okay, multiply by 80 to get the older units. But just using this formula, it's Wood's unit. Okay, again, your systemic vascular resistance reflects the left ventricle have to load. That's the resistance that the left ventricle have to overcome to pump the blood out. And then your pulmonary vascular resistance reflects the right ventricle have to load. So that is the resistance that the right ventricle have to overcome. So these are the stuff that we're gonna measure when we evaluating someone with left to right shunt. And we just went over all the stuff that you're gonna measure, all the parameters you need when you do a right heart cath. Okay. Sometimes you don't go through all of this, all of these measurements, because if you do, if say for instance the patient have COPD, chronic obstructive pulmonary disease, and they have an elevated pulmonary pressures, you don't have to do your oxygen step up and stuff like that. If you're not sure of the etiology of the elevated pulmonary pressures, if you have someone with elevated pulmonary pressures and you're not sure of the etiology, then you have to go through everything, all the steps. Okay, so you have to do your oxygen step up because it could be a left to right shunt. You have to do your pressure measurements. You have to do you might have to do angiogram depending on what. You have to do measurements of your vascular resistance. So this is a complete right heart catheterization. Okay, this is a complete right heart catheterization. So again, you need to go over it, fully understand it, and if there's any questions, then we'll